This conference will now be recorded.
Bismillah ar-Rahman ar-Rahim. Welcome all to this session. My name is Rasha Saad, and we are going today to discuss 5 stations related to Gyneoncology module. We will practice 5 stations on endometrial hyperplasia with and without atypia, endometrial carcinoma, borderline ovarian tumors, and ovarian cancer. And I will also discuss about important points on how to approach breaking bad news stations. So let's start by the first case. Dr. Seema.
Hello, Assalamu alaikum.
Walaikum salam. How are you, Dr. Seema?
I'm fine.
So here is your case, and now you have 2 minutes. Are you ready?
Okay. Hello,
Let's
I'm
start.
Dr. Saima, one of the senior doctor in the. Okay. Hello, I'm Dr. Saima. I'm one of the senior doctor in the gynae clinic today. May I confirm your name and age, please?
Yeah, my name is Mrs. Mary William. I'm 60 years old.
May I call you Mrs. William?
Yes, it's fine.
Okay. Mrs. William, I understand that today you are here because you have some problem related to vaginal bleeding, and you have undergone an ultrasound, and a sample was taken from your womb, and you want to discuss the report. Am I right?
Yes, that's right.
Okay. So, Mrs. William, is it okay before discussing your report, I ask you a few questions to know more about you, because today we are meeting for the first time, and then we will reach at a safe and mutually agreed plan. How does it sound to you?
Yeah, it sounds good.
Okay. So, Mrs. William, can you please tell me more about your problem?
Well, actually, in the start, I'm not worried when I have an attack of bleeding, which lasts for about 2 days, and this occurred about 3 weeks ago. I'm not worried at the time, but I have a conversation about with one of my customers and told her that my period are over, but then I got one. And at the time, this customer told me that I need to report this to my GP. And her sister was diagnosed with cancer of the womb with the same complaint. So I made an appointment with the GP, and on the next day I made a scan, and then they take a sample of the lining of the womb, and now I'm really worried that this could be a cancer.
Okay. Mrs. William, I can see you are worried. So, before discussing your report, I want to ask some more questions. Is it
Yeah, that's
okay?
okay.
Okay. So, when your periods ended,
I don't have periods since the age of 50.
since the age of
50.
uh, uh, when you had your menopause,
Yeah, at the age of 50. From that time, I don't have any period
50.
at all,
Okay.
apart from
Okay.
the first attack
Okay.
I had.
And okay. And were you taking any hormonal replacement therapy after that?
No.
Okay. And prior to ending your periods, were your periods regular?
Yeah, it used to be regular.
Okay. And have you ever been diagnosed with a condition like polycystic ovarian syndrome?
No,
Okay. And when did your period started? At what age?
I can't remember actually.
Okay. And I can understand from your GP letter that you have 3 kids. So how they were born? By
All
C-section or
vaginally.
no? Okay. And you breastfed all your children?
Yeah, it was since a long time.
Okay. And I can also see that you have diabetes and increased blood pressure. So are you following regularly with your GP?
Yeah, all under the control.
Okay, that's good. And have you ever undergone any surgery?
No,
Okay. And are your smear up to date and normal?
yeah.
Okay. And is there any family history of concern you want to share with me? Any
All of my
history of
family members have hypertension and diabetes.
okay, and any can history of cancers like breast cancer or womb cancer?
No.
Okay. And Mrs. William, whom do you live with?
Yeah, I live with my partner and he's very supportive to me.
Okay, that's good. And Mrs. William, do you smoke, drink, or take any recreational drugs?
No.
Okay. And Mrs. William, is it okay if I examine you in the presence of Chevron?
Is it
I will just
essential?
examine your tummy. Okay, so I will just examine your tummy and then I will examine from down below. Okay?
Actually, doctor, I'm really worried about the results. Could you please take me through the results of the report?
Okay. Okay, so let's coming to your report. Mrs. William, I can understand that you are alone today. Do you want to join someone during consultation?
No. Why?
Okay. So, Mrs. William, I'm afraid I don't have a good news for you.
Oh, what's happened?
Uh, just I'm trying the picture of the womb. This is the womb, and this is the lining of the womb. So, this report tells that the lining of the womb has thickened and the cells are increased in number, although the cells are not abnormal. So, it is not cancer.
Oh, it's not cancer.
Okay, Mrs. William,
I think that you are
it is
about to
not
tell me
cancer.
that I have the cancer. That's a relief. I don't have cancer.
No, it is. Yes, it is not cancer, but you need further treatment because if we don't treat this condition, it might be converted into cancer in a long period of time.
Oh,
Okay? Okay. So, Mrs. William, do you want me to continue with the management plan?
oh yes, of course.
Okay. So, Mrs. William, I can see that your weight and height ratio is 53. So, have you ever tried to quit your weight?
Oh, actually, I tried from people
Yes.
telling me to reduce weight. I'm very busy and I don't have time to make fancy salad. And I really wonder what more exercise could I do to reduce my weight?
Okay. Mrs. William, I can understand that it is difficult to lose weight, but because when the BMI or weight and height ratio is more, the body has more fat. So this fat is producing a hormone called estrogen, and this estrogen may be the cause that your lining of the womb has become thickened. So if you reduce your weight, your condition can improve by simply weighting the loss losing the weight. So I can put you in contact with a dietitian. They will tell you different dietary measures and they will advise you different exercises and it will help you a lot. So how does it sound to you?
I tried a lot, but without any benefits.
Yes, they will tell you different exercises, and they will tell you different dietary measures, and there are different programs. And by going through this, it will be a really great help. And and it will also help you to control your blood sugar and blood pressure also.
Okay, let's see what he will do.
Okay, so the next management plan is that we can give you some, either we can wait for a small period of time so that your sampling can be done after 6 months, or second, we can give a medicine called progesterone. It can either be given as oral medication, or sometimes it can be given as coil, which is called as Marina coil. It can be
No way. When
inserted.
they take the sample from my womb, it was very painful. It brings eyes to my bring tears to my eyes. I really don't want any maneuver to be within my womb.
Okay, I can understand it must be difficult for you, but Marina is the most suitable option because there are increased chance of improvement by this method. And if it was painful, we can advise you some pain medication before undergoing
No,
this
Dr.
procedure.
Again, this treatment. I don't like to have my renal.
Okay, so if you don't want Marina, then we can give you some oral pills, and it contains the hormone progesterone, and you will use it for a period of 6 months.
Okay.
Okay, and we will take again the sample of your womb after 6 months. Okay.
Oh, again, I will have another sample?
Yes, because Mrs. William, there are chances that this problem can progress to development of cancer. So we need to confirm that either it is improving or it is progressing.
Oh, what is the chance of it going to have to be cancer? Is it common?
The chances are very little, and if we in the 20 years period, there are less than 5% chances that it might be converted into cancer. Okay, but this treatment is very simple, and there are high chances that your condition will improve.
Okay.
Okay, so once this sample after 6 months becomes normal, we will repeat another sample after 6 months, and once 2 samples are normal, then you will have to undergo annual test. Am I
Oh,
clear so far?
so no way. I will have this sample again many times. Is there any other option?
Uh, the last option is that you can undergo a surgery for the removal of the womb. Okay, and as your periods have ended.
Time's up.
Okay,
Okay, Dr. Seema, tell me
thanks.
about other things you'd like to tell her.
I can tell her option of hysterectomy.
How you will counsel her about hysterectomy?
Hysterectomy is a major procedure, and it can be done by a keyhole surgery. And as she is menopausal, we can also remove her ovaries. And after that, she may need a hormone replacement therapy.
And will you recommend this option for her?
If patient is not willing to undergo this follow-up, or if her bleeding is not improving, then we can undergo hysterectomy.
You will not
Patient is
try to
not.
convince her to avoid the surgery? You will not try that?
Yes, surgery. We will
Why?
counsel about different risks of surgery, like
Yes,
anesthesia, and there can be damage to the different organs like bladder,
especially
ureter,
that,
bowel.
especially what? You will counsel her against the surgery because of what? Her
Because
BMI, her
it has
BMI.
risks.
Her
BMI is
BMI is
also large.
63.
Yes.
Yes, so you can use this
Yes.
information in her counseling. Okay, any other thing you'd like
Yes.
to
Yes.
add?
And then I will offer her patient information leaflets and different support groups.
Okay. Okay, Dr. Seema, thank you very much. You did it very well, but as usual, time is not enough to say everything you'd like to say. But coming to the post point you did from the start, you confirmed the aim of the consultation and you put your agenda and you start by an open question. So the role player told you the whole story. And it was really helpful from you that you ask about HRT and you need to roll out PTO as a risk factor. And you ask about the smear, and when you explain to her the diagnosis, you draw and you counsel her about the weight and you do a referral for a dietitian. But other things that I'd like you to add next time when you do this station is don't ask when your period ended. She is now 60 years. Better to ask her when did you go through menopause. So it will be more specific. Okay. The other thing that you
Okay.
ask about non-relevant information, what you will gain if you ask her about breastfeeding, especially she is now 60. So don't ask irrelevant question. It seems that you are not taking target history. The other thing that here in this situation, the woman come and she's worried she has cancer. So what do you think? When I told her that it is not cancer, am I going to follow Breaking Bad news approach?
Mm.
What do you think? Now I'm really worried that I have cancer, and you told me you don't have cancer. Still, there is risk. I agree with you. There is risk to develop to cancer, but it is a small risk. So I think
Okay.
it is not follow Breaking Bad news station. We can
Okay.
follow this in another scenario, like if it is a woman young age and she has irregular bleeding, and on further management you discover that she has endometrial hyperplasia, especially if this young woman is keen to have future children, at this time it will be Breaking Bad news. So it depends on the situation. If the patient is concerned to have cancer and it is not cancer, not Breaking Bad news. But on the other hand, if this management plan will affect her future fertility, which she is keen about, so it will be Breaking Bad news. Do you agree with me?
Okay. Yes, yes.
The other issue is this patient is reluctant to lose weight. And in this situation specifically, this woman has BMI of 53 and she has comorbidities, diabetes, hypertension, endometrial hyperplasia. So you can discuss with her that the dietitian may counsel you on surgery, named bariatric surgery. It will be a good option for her. Just emphasize this point.
Okay.
And on counseling the woman, you start counseling in general by telling her, I'm going to discuss with you all the options, and at the end, you will choose what is suitable for you. And go every option one by one, risk and benefit. Risk of nothing, wait and see, it not be recommended in your case because you have many risk factors like the BMI, 53 is high risk, and hypertension as well. So it is not recommended. The other option is medical treatment, and you discuss about Mirena and oral. And the last option is surgery, then discuss about the risk. Then what your recommendation? It is recommended as a first line to insert the Mirena. But because she is against this option, you can counsel her about the oral as you did. And the last thing I'd like to tell you, try to, when you start your diagnosis, you tell her that you have a condition named endometrial hyperplasia, and by the end, I will give you patient information leaflet and put you in contact with support group. Don't leave this till the end of the station because you will not have time for it. Okay?
Yes. Yes,
Apart from
doctor.
that, you did it very well and you cover most of the part. Thank you, Dr. Simo.
Thank you, Dr. Rasha.
You're welcome. Okay, so what I will do in the full station when I read this station outside the cubicle, important point that I'd like to emphasize that what type of task is it? It's a role player task. What domains being tested? And look, for every station, you will have patient safety and applied clinical knowledge. But what I'm going to look for is, does it contain information gathering? So I'm going to take a detailed history, and does it contain communication with colleagues? So I will write down in my notes whom I will communicate. Let's say it's a case of cancer, so I will write in the notes MDT. So I will not forget when I start the cubicle. So I will determine the type of the task, it's a role player. I will see if there is information gathering, if there is communication with colleagues. Patient name is important, her age, all of this need to be written in the notes. The BMI, so I will not forget to counsel on weight loss, her diabetes, hypertension, she has 3 children, and what is the diagnosis? She has postmenopausal bleeding and the diagnosis is hyperplasia without atypia, and what is needed from me is to explain the biopsy result and the management plan. Here, how can I approach this patient in only 2 minutes? Determine the type of the test, domains tested, and important points in the station. And if I still have time, I will try to remember important points of safety related to that topic. So what are the important points here? As Dr. Sima did, confirming the aim of the consultation from the start, I can see that you are here because you are about to discuss about the result of the sample taken from the lining of your womb because you suffered an attack of postmenopausal bleeding. Is that right? So I confirm the aim of the consultation. Then you start putting your agenda and start by an open question. Tell me more about your concern. At the time, the role player will tell you everything about the story. And if it is not covered, you need to ask the following question. When did the bleeding start and for how long it lasts? And was it heavy? And is there any treatment received? In bleeding, you need to ask this question. When it started and was it heavy? For how long it lasted? And any treatment received? Then we need to ask about risk factors for endometrial carcinoma. As she did, the age of menarche, the age of menopause, because delayed, early menarche, and late menopause are risk factors. If she has HRT or not, and if she is on many medication. You forgot also, Dr. Sima, to ask about medication. And when we ask about medication, we need to show the examiner that I am looking for tamoxifen. So ask her, are you taking any medication like tamoxifen? And also, don't forget in any station to ask about allergy. You are going to give her oral progesterone. So don't forget also this point. Then go through the other risk factors like obesity, like PCO, and family history of cancer. Then explain the diagnosis in lay language, draw, and tell her that here's the lining of your womb. We have thickening of the lining of womb, which is due to rapid growth of the lining cells without any abnormality in the structure of the cells. We name this condition hyperplasia without atypia, and it is not cancer. Here's how you explain endometrial hyperplasia. Draw and tell the thickening of the lining of womb due to rapid growth of the lining cells without any abnormality in the structure of the cell. And don't forget to say it is not cancer, say it clearly. And on the other hand, in other station, if it is cancer, you need to say it clearly, it's a cancer. So determine with the role player if she has cancer or not. Then we need to be open and honest about the complication. Still, I will not follow breaking bad news approach in this station, especially this woman is worried that she has cancer and she doesn't have cancer, but still I need to tell her about the complication. So I will approach this like the good news is you don't have cancer, but still there is risk of complication. Would you like to know about this complication? She will say yes. Then go through it. There is a risk of progression to cancer, which is less than 5% over 20 years. And the majority of cases will regress spontaneously during the follow-up. Then discuss about your option, but we need first to emphasize the importance of losing weight. And how can I explain to the role player this sensitive issue of obesity? For sure, I will not tell her you are obese. I will tell her, Mrs. Mary, I can see that your weight is on the higher side. So it will be a good idea to try to lose some of weight. Then tell her why we need to lose the weight. Because endometrial hyperplasia is caused by excessive or unbalanced effect of hormone named estrogen. And this can happen with high BMI because this hormone is produced by fat cells. That's why we recommend losing weight. And to help you, I will do a referral for a dietitian who will help you with that, and he will discuss with you different options, and he may consider a surgery to help you lose weight named bariatric surgery. Then I'm going to discuss about options for treatment of endometrial hyperplasia without atypia. And when I will discuss the option, I will tell her clearly, I'm going to give you your options. I will try to explain the risk and benefit, and by the end, whatever you choose, you will be supported in your decision. Then go. The first recommended treatment is levonorgestrel iodine, a hormone coil named Mirena. And it is the first recommended line. And when she tells you that the sample was very painful, and I'm against that option. Yeah, it's okay. There is other option, which is oral progesterone, and you don't need to know this dose, but if you need, it's medroxyprogesterone 10 to 20 milligram per day, or northisterone 10 to 15 milligram per day. And the other option will be removal of your womb, and as long as you reach the age of menopause, so we will remove also the tubes and the ovaries, and this could be through keyhole surgery, but it is not recommended, especially that you have high BMI and because of associated morbidities like hypertension and diabetes. Then you need to emphasize that the oral progesterone will be taken continuously for 6 months. Then we will have a follow-up by another endometrial sample every 6 months until 2 negative samples, then to be done every year, as Dr. Seema said. And don't forget to involve the consultant and give her patient information leaflet and support groups. Okay? Anyone have any question related to this station? Any question?
So, ma'am, she'll keep getting endometrial biopsy done every year till what time?
Forever, because she is high risk to develop endometrial cancer. Because she is obese, she has BMI of 53, so she needs to be on continuous follow-up.
Okay,
Is it clear?
Hello,
yes,
Dr.
Dr. Rasha, I have two questions.
Yes.
One is that this patient will need biopsy after 6 months. And
Yes.
then if negative, then we will repeat after 6 months. But suppose it is persistent or it has progressed, in that case, she will not need a biopsy. And if only 2 biopsies we need to do, like when we start treatment, after 6 months, we will do the first one. And then again, after 6 months, we will do the second one.
Yes,
It
that's
is not
right.
that.
Yes, that's right. If the patient don't have risk factor for endometrial carcinoma, we will do the follow-up by 2 endometrial samples 6 months apart. But here, because the patient is high risk factor because of the BMI, after 2 negative samples, you will not discharge the patient. You will continue the follow-up every year.
Yes, and my second question was because I heard that about HRT, because she is already above 60 or something, so she will not need HRT, or
Yeah, she
does she
cannot
need?
need, yes.
Okay. Thank you so much.
We didn't discuss about it, but we need to ask her if she has received any HRT, because if she is taking estrogen alone HRT, it is one of the risky factors for endometrial carcinoma. That's why we ask if she's taking HRT or not.
Okay, thank you, doctor. Thank you so much.
You're welcome.
Assalamu alaikum, Dr. Rasha.
Yeah, hi, Dr. Salma.
Fine, thank you. How are you?
Yeah, I'm fine.
Dr. Rasha, if the case is that endometrial hyperplasia with atypia, then it will be breaking bad news?
We will discuss this in the next station.
Okay. Okay, sir.
Any more questions? Shall we move?
Hello, ma'am.
Yes,
If
hello.
patient does not improve and suppose she has persistent endometrial hyperplasia or her disease is progressing and we have to do the TS with BSO, then will she need HRT or not?
Will she need, sorry, what?
After hysterectomy.
Yeah, after hysterectomy.
Yeah, will she need HRT or not? Estrogen, because after TH with BSO.
We will discuss this also in the next station. Okay. So because both stations are linked together, let's discuss first the second station, then we will reply to every question. Okay? Who would like to check?
Okay, thank you.
You're welcome. Who would like to share the next one?
Dr. Rasha, can I do the next statement?
Yes, sure.
Dr. Rasha?
So we have 2 candidates here. Doctor, who is talking?
Dr. Shagufta.
Dr. Jagofta and Doctor, the other one? Okay, so Dr. Shagofta for this case, and you will be for the next one. Okay?
Thank you, doctor.
You're welcome.
Dr. Rasha, can I do the next one after that?
Okay, okay,
Thank
okay,
you.
Doctor. So, Dr. Shagufta, now you have 2 minutes. Are you ready?
Yes, Dr. Rasha.
Let's start.
Hello, I'm Dr. Shagufta, one of the doctors in the clinic. May I check in your name and age, please?
Oh, you know my name, doctor. It is the 3rd time we meet together. My name is Mrs. Mary William.
Yeah. Can I just cross check your age, Mary?
Isn't written on your notes? I'm 60.
All right. Okay. So, Mary, how are you doing?
Yeah, I'm fine.
Okay. So Mary, you are here. I mean, as I can see from your notes that you just had a sample from the lining of your womb, and you're here to discuss the results. Is that right?
Yes, right.
Yeah. And okay, so Mary, I'll discuss your report, and I'll also discuss all your management options. Can I take a few questions first?
Okay.
So, can you tell me how has your, I mean, you had this problem of bleeding. So, how bleeding after menopause, like is after stopping your menses. So, how has that been recently?
Oh, I thought you are aware about my case. As you know, doctor, I've been suffer from a condition named endometrial hyperplasia without atypia, and you counseled me to have oral
Yes,
progesterone
yes,
and to continue
yeah,
to follow up with you. And this is my 3rd biopsy.
yeah, yes, yes, Mary, I can see this. I'm just asking, how is your bleeding now? Do you still have bleeding?
No, I don't have. No, it's only one attack.
Okay. So, Mary, I have your report here with me, and has anybody spoken to you about this report, Mary?
No,
Mm-hmm. Okay. So, Mary, do you have anybody here with you to support you while I give this report?
no, why?
Mary, can I call in my nurse to sit with you while I give this report to you because I'll be giving you a lot of information, Mary.
What's happened, doctor? I'm really worried.
Uh, Mary, I'm afraid I don't have. I don't have very good news. The doctor who examined the lining of the cells of your womb
Hello.
under the microscope has some concern about your report.
I'm sorry, because your voice was interrupted. Your voice was interrupted. Could you repeat it, please?
Uh, uh, Mary, I don't have very good news. the doctor who examined the cells under under the microscope has some concerns about your report.
Oh, what is that?
Maybe as you, I mean, you had previously what we call the thickening of the lining of the womb, but the cells did not show any sinister changes. This time the report, it shows that your this condition has progressed. So let me just draw for you. So this is your womb, and these are the cells inside the womb, and these are the normal cells. These normal cells, they look like something like this, and then this is what we call the cancer cell. Okay, and your report shows something in between. So this is something in between. All right.
So it is cancer or not? I
It
can't
is.
understand you.
Yeah, it is not cancer as of now, Mary. But if we don't treat it now, it can turn into cancer.
Oh,
Hmm.
yes, I got it. So what I will do now?
Mary, this report, uh, you will be referred to a team of specialist doctors, which we call the multidisciplinary team, which will consist of my consultant, also the specialist in these, I mean, uh, this specialist, and also a specialist nurse, and and also a doctor who examines these cells under the microscope. And they will sit together, and along with you they will discuss this report. They will review your any scan reports which you have, and also this report of the lining of your womb, that is called endometrial biopsy, and they will form a management plan for you.
And what are the options?
Yes. So maybe the options in this case, because as I told you that this cells have started. I mean, they are something in between, and if we don't treat them, then this can turn into cancer. So the options in your case, the recommended option is to go for the removal of the womb.
Oh, doctor, I told you from in the next time that what if I'm going to the removal of the womb? If you follow my advice, this could not happen.
Maybe I can understand your concern, and I'm really sorry that I'm really sorry that our care did not meet your expectations. But Mary, the thing is, you had this. You had the sinister. The changes were not sinister earlier, and they are still not sinister. But as I told you, that they can turn into sinister changes. And earlier, I just would like to ask, you went to the dietitian for the diet and exercise program, because my colleague, she also told you that your weight is a bit on the higher side, and it would be recommended that you lose a bit of weight.
Yeah, I tried that, but still something went wrong.
Pardon?
Still something went wrong. I just query. You tell me there is a chance to pass to cancer, and even in the first time you told me there is a chance to develop to cancer. What are the differences?
The difference is, as I told you, that this is something. These cells are something in between. So the chances of these type of cells to develop into cancer, it is about 25 in 100 women. Like it's about 1 in 4 women.
Oh, yeah.
Yeah. So I know, Mary, that you think that we could have offered you the removal of the womb earlier itself. But the thing is, generally, the recommended treatment for that, when the cells are not sinister, is usually the hormonal coil, or the oral all the oral hormones.
Mm-hmm.
Yeah. So, Mary, do you want me to discuss about this surgery? Do you want me to
Yeah.
discuss about the surgery further? Yeah.
How are you going to remove the womb?
So Mary, the thing is, we need to just can I confirm your BMI earlier was 53. So has it changed in any way?
Yeah, it has been improved, but it's still high. I think it become now 51.
Okay. And you went to the dietitian. Did they offer you anything?
Yeah, he told me about the surgery, but I refused.
Pardon?
He told me about the surgery to help me lose weight, but I refused.
Okay. Okay. So the thing is, Mary, the options is to removal of your womb, as we'll also remove your, I mean, because you have stopped your period, so removal of your womb, and according to your wishes, it will be removal of the ovaries and also your tubes. Okay. So this surgery, it can either be done either by keyhole surgery, or it can be done by an incision in your bikini line. All right.
Okay.
So do you have any specific preference?
I don't know what are the differences. What's your recommendation?
Okay. So the thing is, because any surgery has its own complications, and because you have a bit, as I said, that your BMI is on the higher side, so no surgery is without any risk, and in your case, the surgery will be a bit more tricky. All right. So the keyhole surgery, what we do is we do it by making small holes in your belly button, and we put you to sleep, and then we make small holes in your belly button and in your tummy, and we remove we remove the womb and the tubes and the ovaries by what we call the keyhole surgery. All right.
Okay.
Yeah. So the good thing about this surgery is that you can go home early and your recovery will be early, and also you will be able to resume your normal activities early. But because your BMI is on the higher side, and there are also other risks associated with this surgery, like there can be injury, there can be, we may even fail to enter the tummy. All right.
Okay.
Yeah. And also there can be injury to the adjacent structures like the water bag or the bowel, and also, yeah.
Time's up. What else
Yeah.
you'd like to add?
So the other option, yeah. So the other option is we make an incision in your bikini line, and we remove your womb, your tubes, and your ovaries. Uh, your recovery in this case, I mean, will be a bit. You will have to stay in the hospital for 3 to 4 days. And in the
Okay,
keyhole
apart
surgery,
from
you need to
counseling
stay.
here about hysterectomy, any other things you would like to add, Dr. Shagufta?
Any other option?
Would you like to add anything to the station?
I would just tell her that she will, of course, I mean, that the background risk of cancer, risk of cancer in this case, maybe, it may be as high as 4 in 10 women already may have cancer, and of course, the specimen of the womb and the tubes and ovaries will be sent for examination, and we'll have to follow her up, and the surgery will be done by a experienced person because she has high BMI.
Okay.
And also we put her in touch with the anesthesia or the pain doctor so that pain relief can be discussed for her.
Okay. Could you give her a leaflet and put her in support group?
Yes. Also, I would offer her referral to. I mean, I would refer her to the counselor because I know this is difficult news for her, and also I'll give her certain support group numbers, and
Yes.
Because it will help her to talk to people who are going through things.
Yes. Okay, Dr. Shagufta, thank you for your sharing.
Thank you so much, Dr. Shah.
No worries. So you did it well, and you confirmed the aim of the consultation, and you draw while explaining for health diagnosis, and you discussed about the entity, and you discussed about the option of hysterectomy very well by discussing that we can do through keyhole surgery or open one, and you recommended for her because of high BMI to be through keyhole surgery. But from the start, the way of introducing yourself, if it is task linked to the previous station, will be different. And I will discuss this within a minute. And also, don't forget when you explain to the role player a result of a report to confirm her name and the hospital number before reading the result, especially if it's breaking bad news. Because she will tell you, are you sure, doctor? So at this time, you will tell her, yeah, this is your name and this is your NHS number. Yeah, I'm sure about the result. So instead of being in such situation from the start, before reading the result, confirm the patient name and hospital number. And be careful because it is written in the station, this woman was under your care and for follow-up of endometrial hyperplasia without atypia. So don't tell her that my colleague told you. No, you are the one who is following her. So be careful to be aware of the situation. And also, when I told you from the start to have a surgery, why you don't recommend it. So you need at the time to emphasize that this option is not recommended because you have associated risk factor which may make the operation more tricky because of your weight on the higher side and because of associated diabetes and hypertension and because of most of women in your previous diagnosis will show spontaneous regression and improvement without need for any further surgery. Okay, Dr. Shagufta? And
Yes,
also,
Dr. Rasha, thank you so much.
You're welcome. And please all follow the advice of mentioning the patient leaflet and support group when you discuss about the diagnosis. Believe me, you will not have time to do that. And it's a guaranteed mark. So when you tell her about the diagnosis, you have a condition named endometrial hyperplasia with atypia. So now I will give you a patient information leaflet and put you on support group by the end of my discussion. So I will take this mark. Okay?
Okay, yes, Dr. Rasha, that's a good idea. Get it over with before itself.
Yeah.
Thank you.
Thank you, Dr. Shalom. So now what I'm going to emphasize during the 2 minutes, please all, if anyone wanted to write it in general, because I cannot concentrate on these private messages. Write it on general, okay? Is my voice interrupted? My voice clear for everyone? Could you confirm it, please?
Yes, it's clear, Dr. Rasha, it's clear.
Yes, ma'am. Yes, ma'am. Your voice is clear.
Okay, so now during the 2 minutes, what I'm going to do, again, I'd like to determine what type of task I'm going to present on the next station. So it is the role player task and it's linked to the previous station. And linked the station have different approach. The other thing is that what domain being tested, and I'm going to look if there is information gathering. So I'm going to take a detailed history. If there is communication with colleagues, so I will write on my notes here MDT. The other issue is this patient was under my care and for follow-up. And here is the second biopsy. And my task is to explain the diagnosis and make a management plan. If still I have time from those 2 minutes, I will try to remember important point of patient safety related to this diagnosis. Now, when I enter the cubicle, the way of introducing myself will be different because I already know this patient. If you have time, read the other points you write in your notes in the next, in the previous station. You know the patient name, you know her BMI, you know her age, you know her initial problem. So you are aware of all this history. So instead of asking her, you will confirm this data in front of the examiner. Like I will introduce myself in this way. Hello, Mrs. Mary. Nice to meet you again in the clinic. How have you been since your last visit? So here I'm aware of the situation. This is not the first time I see this patient. I know her name. I know her problem. So the way of, and also she know my name. So I will tell her, hello, Mrs. Mary. Nice to meet you again in the clinic. How have you been since your last visit? Then confirming the aim, I know that you are here today because we will discuss about the result of your second biopsy. That's right, yes. Then, do you have any expectation to our consultation today? She will tell you no. So now, because in this station, the examiner is not the same examiner in the previous one. So I just would like to emphasize that I know important point of history related to this woman, but not asking her. I just confirm. I will tell her, just I would like to confirm that you suffered an attack of postmenopausal bleeding about 1 year ago, and you was under our care, and we opted together for oral progesterone, and this is your second biopsy. Is that right? And I just would like to confirm that you have hypertension, you have diabetes, and that we made a referral to a dietitian. What about your weight management? So you will confirm the data. You will not ask again the same question. Although it is another role player, but it's a linked station. So try to be aware of the situation. The second thing is, it's a station now of breaking bad news, because this woman was under our care. Her first sample was free, no atypia, no any further progression, but now the diagnosis will change. She turned to have atypia. So now it's a breaking bad news. So let's talk how we approach breaking bad news. Breaking bad news from the start. When I started breaking the bad news, my tone of voice needs to be changed. Not the same tone of voice I started the station with. So I will tell her, give a warning shot and tell her, I can see you come alone. You want me to ask the nurse to attend, as I'm going to give you a lot of information. Then wait and tell her. So, Mrs. Mary, I'm afraid I don't have very good news for you today. Wait for seconds until the results reveal that you have, then tell her about the diagnosis. And show empathy. After telling her the diagnosis, I'm very sorry about this. Then wait. If she started to talk, it's okay. If not, tell her, count for 10, then tell her, I can understand that this might be quite difficult. And would you like to postpone the consultation until you will be fine? For sure, she will tell you, no, it's okay. So would you like to discuss about your option? Then start your consultation. So again, how we break bad news. The tone of voice, change your tone of voice. Give warning shots. Can see you come alone. You wanted me to ask the nurse to attend, as I'm going to give you a lot of information. Mrs. Mary, I'm afraid I don't have very good news for you today. The result reveals that you have, and then tell the diagnosis clear and simple. And be careful. If it is not cancer, again, tell her that it is not cancer. And show empathy. I'm very sorry about this. I can understand that this might be quite difficult. And if the patient cries, be silent. Don't interrupt her. Just give her tissue. Here is tissue. Count 10 in your mind. And if she doesn't talk, tell her, do you want a glass of water? Do you want to postpone the consultation until you will be fine? Then she will start talking again and continue your consultation. Here is how we can approach this station of breaking bad news. So how we are going to explain hyperplasia with atypia in lay language. Draw again for her until there is thickening of the lining of your womb, but it is due to rapid growth of the lining of the cell with abnormality in the structure of the cell. It is not cancer. Emphasize this point. It is not cancer. But the issue is that it is associated with many complications rather than your previous diagnosis. There is a risk of associated cancer, but of course I will not tell her all of this during breaking bad news. I will just tell her there is a change in the diagnosis and your condition now turn it to another condition named hyperplasia with atypia, which is thickening of lining of womb due to rapid growth of lining of cell with abnormality in the structure. Then wait until she can understand this information, then tell her this condition associated with many complications, like there is a risk of cancer in 30 to 50%. If you cannot remember this figure, just tell there is a high risk of cancer. Associated cancer, yeah. I mean that even the samples show endometrial hyperplasia with atypia, still there is associated risk of cancer in 30-50%. Besides that, there is a risk of progression to cancer over 20 years is up to 50%. And again, if you cannot remember the figure, just tell her there is a high risk of associated cancer, and there is a high risk to be progressed to cancer over 10 years, over 20 years. Then I will discuss with her about the options for her now, that her care will be under MDT, and usually they will recommend a laparoscopic approach to remove the womb and post tubes and ovary as long as she is post-menopause. So when she told you why not surgery from the start, so tell her I appreciate your concern, but let me explain it to you. The risks of the surgery at that time were greater than its benefits, especially because of the associated medical condition you have. You have diabetes, you have hypertension, your weight was in the higher side, And also, most of conditions show spontaneous regression during the follow-up without exposing them to the associated risk of surgery. That's why surgery was not recommended at that time. But now the diagnosis is changed. That's why it's recommended now to have a surgery. And of course, don't forget about MDT. And you can add also in this station some items about enhanced recovery program. So I'd like to write a letter to your GP to help to control your diabetes and hypertension and your weight also before the surgery. And you can counsel her about the benefit of keyhole surgery, that you will have a rapid recovery and so on, as you know. And don't forget, of course, about the leaflet and support group. Is it clear now? Any question?
Thank you, Dr. Rasha. It is very clear.
You're welcome, Dr. Saad. Thank you.
Hello, good evening, ma'am.
Yeah, good evening, Dr. Sumaira.
Sumaira, yes.
Yeah.
I have few questions. In that patient, if the BMI is high, like that patient, if we are if we are advising that patient for surgery in MDT, can we have to advise or we have to involve tissue viability nurse at that point of time or not?
You need to involve what? Sorry?
Tissue viability nurse.
Tissue viability nurse? What do you mean by that?
Because that I saw in one scenario that if the BMI is high, so there is a more chances of pressure sores or so. For that, from that point of time, that we have to involve them or not, just that question.
At that time, because it is not a station of obesity, counseling about obesity, although you need to emphasize that having a high BMI will make the operation more tricky, and that's why we need to apply the enhanced recovery program and tell her important point about that program without going into more details. It is not the time to do that.
Definitely, yes. Okay, thank you.
You're welcome. Any more questions?
Dr. Rasha, I have a doubt. Regarding this oophorectomy, can we give an option of oophorectomy to her? Because
Yeah,
sometimes
sure.
granules are said.
You remove the ovary.
Yeah. And one more thing, this enhanced recovery program you have told, in this usually as you yourself told, we refer to a GP for her medical conditions or till her weight is reduced and controlled. Can we give that? It may take some time. That much time is we can give her till like.
Yeah, you need to make the surgery. I agree with you. You need to make the surgery as fast because there is a risk to bust
Yeah,
cancer.
that's what I'm asking.
But at least you can tell her we will try to optimize your diabetes and hypertension, of course, before the surgery to reduce the risk of complication, and you will encourage to be discharged from the hospital as early because the risk of DVT more if she will be admitted for more time in hospital. Just emphasize that you will try to apply the enhanced recovery program. But of course, we will not wait until her weight become controlled and the diabetes and hypertension become controlled. Yeah.
Yeah, thank you. And this oophorectomy, any age we can say, no? Like, for example, if it is being detected at the age of 47 also, I'll be give her 47 or 48. Or
sorry, again?
For example, the patient is around now 48-year-old or 49-year-old, and along with the, if she is willing for, instead of she wants to go ahead with the hysterectomy, that time we can give an option of oophorectomy along with that.
You will give the option of ovarectomy because she already 60 years. She already in menopause, and even she didn't receive any HRT. So it is okay with non-functioning ovary. That's why we will offer the option of ovarectomy.
Oh no, that's what I'm asking. Leave about 60. If she's in younger age, then like 48 or close to 50, 48, 49 years, can we sell because associated granulars or tumors will be there?
Yeah. If it is in younger age, you can counsel. You counsel until her the risk and benefit, and she will decide. Tell her because even if she's still in young age, then don't reach the age of menopause. If she already completed her family, and if it is associated with other condition, like if she has BMS, for example, at the time, yeah, you will counsel her also about ovarectomy. But if she refused, it's okay. But we will remove with the tube. We will do hysterectomy with bilateral salpingectomy.
Okay. Thank you. Yes.
You're welcome. Thank you.
Hello, Dr. Rasha. I have a question here.
Yeah, sure.
Yeah. So if we have hyperplasia without atypia, so we don't need to break bad news. But if it is with atypia, so we take it as a station of breaking bad news also, right?
No, it depends on the situation. As I gave an example before, just imagine in the first station, because the patient was worried she has a cancer, that's why I don't follow the approach of breaking bad news. But another station about a woman who is seeking fertility. She is infertile, and during her workup, you discover that she has endometrial hyperplasia without atypia. But you will tell her, we are going to give you medical treatment that will delay your fertility workup, and we will need at certain time period you may pass to cancer, and still this woman is young age. So in this situation, it will be free from bad news. So don't fix it. It depends on the situation. Put yourself inside the patient so you can determine if it's free from bad news or not.
But even in this station, like this woman, she was expecting her hyperplasia to be resolved. But in fact, it progressed on to atypia. So she was not expecting kind of surgery now. So it has to be bad news here, right?
Yes, because she has already one sample before, which is normal, and here is her second sample. She's about to have a follow-up every 1 year, but now I told her, no, we have another diagnosis and we need to change your management plan. So here it is breaking bad news.
Thank you.
You're welcome. Thank you. Okay.
Dr. Rasha?
Yeah, Dr. Salma?
Dr. Rasha, yeah, you told that if it is patient age is like 45, okay, and we'll remove her that ovary and tube. So at the time we'll offer her for HRT, isn't it?
Yeah, I will discuss this in the next station. The HRT in case of endometrial hyperplasia and even in endometrial carcinoma in younger age. Okay, we will discuss about that.
Okay. Thanks.
You're welcome.
Dr. Rasha, one question, please.
Yeah.
Suppose if this is a patient of 34, 35 years, and if she is looking for fertility, and if her report is endometrial hyperplasia with atypia, so in the guideline they have said that you have to remove both the ovaries, right? So whether we should say that we will be removing both the ovaries, and after that the pregnancy will be just not possible, but you can have baby through adoption. Is that right? Or
you need to make your management plan individualized, depends on the situation. So you said that it's a patient 45, I think, and she's seeking fertility, and you need to remove her ovaries. That's right or not?
35.
35. Yeah, okay. So whatever the case is, you discuss the option of removing with the risk and benefit, and the option of not removing with its risk and benefit. That's it. You need to discuss every option with risk and benefit. Then let the patient decide. Of course, you will tell her about your recommendation, because if we leave the ovary, there is a risk of having any ovarian cancer or any ovarian pathology, which will make the operation more tricky later. But still, you will give her the option of not removing and let her decide. Give her the risk and benefit, and she will decide. Don't go straight away that I will remove your ovaries. No. Individualize according to the situation. That's it.
Okay, thank you.
Dr. Rasa, can I speak? Dr. Rasa?
Yes, Dr. Sharma?
Yeah, Dr. Rasa, I don't think if a patient who is 35 years old and she has been diagnosed endometrial hyperplasia with atypia and she is seeking infertility, we will not remove ovaries. Definitely the decision will be taken by MD.
Yes, I agree with you, yeah. Young age. Yes, I agree with you. It's young age. That's why I told her you need to be individualized the case. Depends on the situation. 35, yeah, it's so young. You will not remove the ovary, of course. But you tell counsel here about the risk of leaving the ovary.
Sometimes, Dr. Rasa, in such stations, we might need to go up till surrogacy also. Suppose she is diagnosed with, she has concomitant cancer and we need to remove the womb. In that case, the ovaries will be preserved.
Yeah, and you know, Dr. Sharda, even in this scenario, if a woman diagnosed with endometrial hyperplasia with atypia and she is refusing the surgery and she's seeking fertility still, We can't rate her medical and don't give her the option of surgery. You can give her high dose of oral progesterone, or you can give insert the Mirena and continue with a follow-up, but to be every 3 months, and go for fertility. And once she completed your family, you can proceed with the surgery. So here the option will be different.
Yes, doctor. Thank you so much.
You're welcome. Any more questions? Okay, shall we move? Doctor, sorry, I forgot your name. The other doctor which want to participate. Unmute yourself, please. Yes, well, Dr. Shahid. Here is your case. You have 2 minutes.
Can I have the next slide?
Oh. Start, please.
Hello, I'm Dr. Shraddha, one of the doctors. May I check in your name and age, please?
I'm sorry, Dr. Shraddha, can you make your voice more clear? Start again.
Hello, I'm Dr. Shraddha, one of the doctor in the clinic today. May I check in your name and age, please?
Yeah,
can
my
I have
name
the
is Mrs. Jan Person. I'm 46.
And what would you like to be addressed?
Mrs. Jan is fine.
Okay. Mrs. Jan, please call me Shraddha. Mrs. Jan, I have seen your notes stating that you had a surgery for removal of your womb from down below, and you are here to discuss the report of the tissue test. Is that true?
Actually, after the surgery, they told me I don't want any further follow-up. I'm really worried why they sent me a letter of an urgent appointment. Why I have been asked to come back to the clinic.
Definitely, I will come. I'll come to it, but before that, I would like to say that my consultant is busy. Will it be all right that I continue with the consultation? And if you still have any concern, I can arrange another appointment with you, or
yes.
of his with you. Okay. So, can I ask you a few more questions to know more about your condition, or you want to know why you have been called immediately?
It's okay.
Okay. Okay. So, how is your recovery after surgery?
Yeah, it was fine. Nothing is significant.
Okay. Can you tell me in detail why did you had the surgery?
Yeah, I have been suffering heavy and regular period. And I have never had any bleeding after sex or spotting in between my period, but the issue is I received many medication for this bleeding, and even my GP told me there is a mass protruding from my downflow, which is prolapse. So they give me many options, but I opt for removing my bone to get rid of all of these problems.
Okay. Okay. Are you okay? Few more questions. Any family history of cancer?
No.
Okay. And with whom do you live?
With my husband.
Okay. And is he supportive?
Yeah, he's very supportive.
Oh, nice to know that. And can you tell me about your pregnancies?
Yes, I have only one pregnancy, which is a test tube baby.
Okay. And are you otherwise fit and fine?
Yeah, I'm fine.
Any allergies?
No.
And do you smoke?
No.
Okay. Is there anything else you want to add?
No. I'm up to date with my cervical smear.
Okay. Thanks for this information. So I have checked the name, age, and NHS number and confirmed that the report belongs to you. Is there someone with you to accompany while I'm giving the report?
Why, doctor?
Because I would be giving a lots of information. Should I ask one of my nurse to accompany you? She will be there to support you while I'm giving the information.
No, I'm really bored. Tell me about the results.
Okay. Mrs. Jane, there is a concern in your report. It states that there is sinister change in the inner lining of the womb, which has...
What did you say, doctor? I have cancer? Are you sure I have cancer?
Yes, you have cancer in the inner lining of the womb.
I can't believe it. I'm going to die?
No, it is not like that, Mrs. Jane. The good thing is that your womb has been removed, and the report also states that the lining, the cancer has not gone too much inside. It is in the...
I can't believe it. I can't believe it.
Can you repeat, Mrs. Jane?
I can't believe it. How does this happen? I have they obtained from me a sample of the lining of my womb 4 months ago, and it was normal. How you tell me now that I have cancer? It was normal.
Yeah, sometimes it happen. Sometimes it happen, and it has come in the tissue diagnosis, and tissue diagnosis is more relevant. More it is more something which deals with more confirmation. Mrs. Shane, do you want me to continue with the consultation?
Yeah, doctor. Tell me, what can I do now?
Mrs. Shane, I'm really sorry to be the bearer of this news. I can see that this is not what you wanted. Actually, Mrs. Shane, we all will act as a team, and we will try to make this news and your journey to it bearable for you. What I will do, I'll put you in touch with the support group also. And there would be a specialized nurse called Macmillan who will be there coordinating all your activity. Do you want me to continue with the further consultation, the further management?
Yeah, doctor. I'd like to know, do I need any more treatment? I already removed my womb. Is it all what I need?
Can you repeat, Mrs. Jane?
My womb is already out. Any more treatment shall I receive?
Yes, as your womb has been removed, but your ovaries, I can see that the ovaries are inside. So that also might require removal. But what is the definitive treatment that will be decided by the specialist team of doctor? I will write your letter to the specialist team of doctor, which will consist of our consultant gynecologist. There will be cancer doctor, the cancer surgeon, the radiologist, the pathologist, and the cancer nurse all sit together, and they will discuss your management. I will also arrange a specialized scan called MRI and chest X-ray for you to know more about whether this sinister change has invaded other structures. Okay.
So has the cancer spread?
This states that the cancer is can you give me 1 minute to go to the report again?
Okay, sure.
No, the report right now states that it is in the inner and the middle part only. It has not invaded the outer part. So it is an early stage, and the prognosis for it is usually good. Okay. So what I will do, I will also, if you wish, I can put you in touch of a counselor also and support group where there are people with similar condition whom you can talk and know more about the condition. Also, I will write back to the GP about our discussion and involve my consultant also inform my consultant also about your case. Do you have any questions so far?
No. Shall I need to have any more treatment?
Yes, most likely you will have more you will have more treatment in the form of a further surgery to remove your wounds and also to look at the surrounding structures if they are.
My womb is already out, doctor.
Remove the ovaries. I'm sorry, to remove the ovaries. In some of the cases,
have another surgery.
Yeah, this could be one of the options. The other option could be they may give you, yes, you may need one more surgery, at least to remove the ovaries. Okay. And after that, you will be offered hormone replacement therapy for your bones and heart. Mrs. Jane, are you all right?
Okay.
Is there someone to accompany you? How are you going home, Mrs. Jane?
It's okay, doctor. It's okay.
Mrs. Jane, we are all with you together, and we will try our best so that you can bear this news. Okay?
Okay.
This is the patient information leaflet of our trust regarding endometrial cancer, so that you can know more about this condition.
Okay.
Thank you for your time, Mrs. Jane.
Thank you, doctor. You did it, and still you have 33 seconds. Really wonderful. Okay, doctor. You did very well, and your communication was really very good. You confirmed from the start that the aim of the consultation, and you realized that the consultant is absent, and you ask her permission to start the consultation on behalf of the consultant. And it's really very nice from you that you ask about the recovery, and you are specific when you're asking about the family history of cancer and asking about social support at home. And before telling her about the results, you checked her name and her NHS number. And also, I like the way you tell her the good thing is the cancer is still in early stage. It's a really good way of communication in such condition. And that you involve MDT and whom will be in the MDT, and you recommend further imaging, which is MRI. But don't forget to ask about cervical smear. And also, you told me your ovaries are still inside. From where do you know that my ovaries are still inside? It's written in the task. She underwent hysterectomy, but it doesn't clear if the ovaries are removed or not. So, if the ovaries already are removed, you will be in not good situation. So, instead, tell her, is your ovaries in or out? So, confirm this information as long as it is not written in the task.
But the good thing is, specimen of, can I interrupt, please? It is written specimen of uterus and cervix only.
Yeah, but at least to confirm this, because sometimes she maybe removes the ovary.
And it was vaginal hysterectomy. That is why I thought.
Okay, I agree with you. Okay. We can go through it, but if it is not clear from the station, ask it before, because the patient around 46 and underwent hysterectomy, usually she will remove the ovary. So if it is not clear, but I agree with you, it is clear in this station. But if it is not clear, it will be better to ask. Okay, no problem. The other thing is when I told you I'm going to have another surgery, you can tell her that still we can remove the ovary because it is the source of the hormone estrogen, which need to get rid of because of the diagnosis. But tell her we can make this surgery through a keyhole surgery. So you will have a rapid recovery and shorter hospital stay and so on. So you can emphasize that we can do it through keyhole surgery. And also the option of HRT, don't say it and run. You need to emphasize that HRT has certain precaution in women diagnosed with endometrial cancer. And if she's concerned, we can make a referral to specialized menopausal clinic to discuss this option. And I will tell you what's the debate on HRT in endometrial cancer. But don't say it only. You need to make a proper referral to menopausal clinic if she wants this option, if she wants this option. The other thing that when I told you, I might have another treatment, you know, it is still early stage because of the histopathological report, but if it is further confirmed that from the MRI or from chest X-ray, she may require further treatment in the form of radiation, radiotherapy. So you need also to tell her about that option. Apart from that, you cover the whole station and you cover most of the body. Thank you for your sharing, doctor.
Thank you so much, Dr. Rasha. That was a great learning.
Thank you. So again, now in the 2 minutes, what I'm going to focus in, again, it's a role player task. And I will check the domain. Is there information gathering? So I'm going to take a detailed history. And if there is communication with colleague, and here there is communication with colleague, so I will write in my notes MDT. The other issue that I have been asked to by my consultant to see this woman, so I will write in my notes consultant absent. So on the start of the consultation, I will take her permission to make the consultation with her in behalf of my consultant. So write it clearly in your notes so you will not forget it. The age of the patient is important. She's 46. What type of operation she underwent vaginal hysterectomy 3 weeks ago. When I find in the station patient underwent operation, write in your notes, ask about the recovery. It's important. The other issue that the patient comes to the clinic unexpectedly. So usually the diagnosis is something wrong. She has cancer, and of course it will be a station of breaking bad news. Then I will read the report. Once I read the report, I will write confirm name and NHS number. So I will not forget that. And even if the 2 minutes finished and I don't have time to read all data within the report, start the station, you're now aware that she has endometrial cancer. But when she comes to the point, does the cancer spread, and I don't read the report carefully, I can, as doctors need, I can take her permission, I tell her, just I'd like to go through your report again to tell you more details about the stage, and then read. But don't leave the patient and spend the time reading in the report without communicating with her. Take her permission to do that. And important point here in the report is that the endometrial carcinoma is grade 1, and that there is minimal invasion into the endometrium, into the myometrium. There is no lymphatic or vascular invasion, and the cervix is free. So it gives me an idea that it is still in early stage, and I can use this during the counseling as you did. I tell her that the good news is it is discovered in early stage, so it will have a good outcome and good prognosis as she did. So what are the important points here? From the start, when I introduce myself, hello, my name is Dr. Rasha, the registrar in the clinic today. May I confirm your name and age? And then tell her, may I see you on behalf of my consultant? Then I will confirm the aim of the consultation. Tell her, I understand that you underwent surgery of removing your womb through downflow, and you have been called because we wanted to discuss about the result of the operation. Is that right? So I will confirm the aim of consultation. Then I will put the agenda and tell her that I'm going to ask you some questions to know about you. Then we will discuss about the diagnosis and your management plan. Then go through the discussion. Don't forget to ask about her main concern. And don't forget also to establish what she already knows about the condition. Then obtain target history. In this history, you would like to ask about symptoms and risk factors of endometrial carcinoma. First of all, ask about the recovery because she underwent the surgery 3 weeks ago. The other issue is, I need to know why she underwent this surgery and is her ovaries are in or out. But it is clear here that the ovaries are in. So if it is not clear, ask this question. Then I'd like to know details about her menstrual history. At what age did your period start? So I'm asking about the age of menarche. And ask if this cycle is regular or not. So I'm rolling PCO as a risk factor for endometrial carcinoma. Ask about different types of bleeding. Is your period was heavy? Any bleeding in your period, in between your period? And are you in a relationship? So sorry if you find this question intruding. Do you have bleeding after having sex? And be careful when you ask about postcoital bleeding. Don't ask the question directly. You need to sign both because it's a sensitive question. And you need to make sure that first she's in a relationship. So when I'm going to ask about postcoital bleeding or postcoital pain, ask first, are you in a relationship? So she answered yes. I told her, sorry if you find this question intruding. You have bleeding after having sex? That's it. Then I also still would like to know about many risk factors, like what about your weight and height ratio, and have you been experiencing any change in your weight, any loss of your appetite, any cough? So I assess if there is any metastasis to the chest. I will ask about problem with bowel, water wart, having sex, and pain. And don't forget to ask about the symptoms. This is the symptoms of endometrial carcinoma. If she has pain, problem with sex, problem with bowel and water work, which could indicate there is metastasis. And don't forget, of course, asking about cervical smear. And then you need to emphasize that this patient suffered bleeding, and the bleeding is not responding to medication. So, of course, the protocol is to take an endometrial biopsy. So ask her, any endometrial sample has been taken before the surgery, and what is the type? Is it done in outpatient or inpatient through a telescope from down below or not? And what is the result? So it is expected that this woman underwent a biopsy. Then it's important for any patient diagnosed with cancer to ask about social history, about support at home, and family history of cancer womb, ovary, bowel, be specific, and tell her what family history you'd like to know. Then going to the result, thank her for sharing this information. I will tell her, thank you for sharing your information with me. Now, I'd like to confirm this is your name and this is your NHS number. This will turn you to break the bad news to the patient. And as we said, I will give a warning shot. Mrs. Jan, I can see you come alone. Do you want me to ask the nurse to attend as I'm going to give you a lot of information? So, Mrs. Jan, I'm afraid I don't have very good news for you today. The results reveal that you have cancer of the lining of your womb. And please, after telling her the diagnosis, be silent. Don't give any more details. Tell her, respond to this information. And tell her, I'm very sorry about this. Then wait. If the role player starts to cry, be silent. Don't interrupt her. Offer her tissue, count to 10, and if she doesn't talk, tell her, do you want a glass of water? Do you want to postpone the consultation until you will be fine? And she will tell you, no, I'd like to know about my option. If the role player asks you, I'm going to die, how can you respond to this question? Tell her, Mrs. Jane, don't think about that. We are all here to support you, and still you have many options available. Do you want to know about these options? So you can use the answer of this question to start your discussion about her management plan. And when you bring him bad news, don't lie to the patient or give false reassurance. Be clear, you have cancer, and still she may need more surgery. She may need radiotherapy. Tell her clearly what stage she has. So don't lie and don't give her a sense of security. Be clear and be careful when you tell her about the diagnosis. Then after that, the good thing is that, when the role player asks the candidate that I underwent a biopsy, why it doesn't reveal this endometrial cancer. So how to answer this question? I will tell her that although all the previous investigation were normal, it's still possible to have endometrial cancer, as the previous sample may not have sampled the whole cavity, and the cancer may be confirmed to the small area. As you know, the false negative rate is 10 to 15. I will not tell the patient, of course, the false negative rate, but I will tell her that still, if you have an endometrial sample and it was negative for endometrial carcinoma, there is 10 to 15% to be false negative, because this sample didn't sample the whole endometrial cavity, and still the cancer may be limited to one area, which is not taken through the sample. That's why it didn't discover during your first biopsy. Then explain the diagnosis in lay language. Draw the womb. Here is the lining of your womb, and we have cancer arising here from the lining of your womb. And through this draw, you can tell her about the stage. That you tell her it is still limited to the womb, and it doesn't invade through the muscle of the womb, and it doesn't reach the cervix. So it seems to be an early stage. So the good news is that tumor appears to be at an early stage, as it is limited to the lining of the womb with no invasion of the blood vessels or lymphatic. So if it is confirmed with further investigations, I can reassure you that prognosis is good and the 5-year surveillance is more than 90%. Then discuss with her your management plan. Her care now will be under a group or a team of health professionals. We name it MDT, and discuss who will be involved in the MDT. And we would like to book you for further imaging, which is named MRI, to confirm the stage of the cancer. If she asked you what is MRI, you can tell her it is a special method of imaging. We use radio frequency waves, and it doesn't use radiation, and the scanner is a hollow machine with a tube running horizontally through its middle. You will lie on the bed that slide into that tube, and another part of equipment may be placed over the part of your body. We are scanning to detect any signal and obtain images we need. So MRI, it doesn't use radiation. It does use radio frequency and strong magnetic field. This is the recommended imaging modality in diagnosis of endometrial carcinoma. Then tell her that further treatment will depend on many factors. But while you may need radiotherapy, still you can need radiotherapy. For many patients, the surgery is sufficient. So I will answer this question of shall I need any further treatment? I will tell her that for most of women, surgery is enough. But sometimes you may require radiotherapy. And if she asks what's radiotherapy, it is use of high energy X-rays to kill cancer cells in the area of the body being treated. Normal cells in this area will be also affected, but they are able to repair themselves quickly, but the cancer cells are unable to do this, and so will be destroyed. This is the radiotherapy. And of course, this woman still has ovaries in, so we need to counsel here that we need to get rid of the source of the estrogen, which is the ovary. So we need to remove both your ovaries and tube, and we could do this through keyhole surgery. We need to arrange a meeting with counselor. Any woman diagnosed with cancer offer a meeting with a counselor and give her patient information leaflet and put her with support group. And the support group for cancer patients in the UK is named Macmillan Support Group. You can see this. I will put you in contact with Macmillan Support Group. Also remember, in the sample device, endometrial sampling, as I said, it has a false negative rate. It is 10 to 15%, meaning that the patient has a negative endometrial sample, still she has a chance 10 to 15% to have abnormality and endometrial carcinoma. 10 to 15% have abnormal or have positive result, although it is negative, because the dilatation is blind. So the most common used method of taking endometrial biopsy in UK is people biopsy. And it is, as you can see in the image below, the people biopsy is a fine pore plastic instrument with a curette-like tip. In the tip, there is a curette-like tip. And inside it, there is a central plunger. This plunger creates a vacuum-like pressure, create a negative pressure when pulled. So we insert this people biopsy. It could be with or without local anesthesia. And once the plunger is pulled back, it will suck a sample of endometrium into the instrument because it creates a negative pressure. Then we will rotate this instrument and remove it slowly while keeping the plunger pulled back. Then insert the sample into formalin and the plunger replaced. Current evidence suggests that women with positive hysteroscopy for endometrial disease, meaning that I do for her hysteroscopy and it's positive for endometrial disease, there is a chance 70% that she has endometrial cancer on histology. I mean that we take a sample through hysteroscopy and the sample was positive for polyp. 70% chance that this polyp will be endometrial cancer on histology. And those with a negative hysteroscopy, still there is a chance 2.5% to have endometrial cancer. That's why we answer the question of the role player, why the sample doesn't reveal that I have cancer. I will tell her that because still there is a chance 10 to 15% that even if you have a negative result from the sample, you have a positive pathology. That's why it doesn't reveal during your first sample. It's a nice diagram about postmenopausal bleeding. As we did, we take a history, examine the woman, and the examination will include abdominal palpation, speculum examination, and the vaginal examination. Then we will assess the endometrial thickness by the transvaginal ultrasound. If the endometrial thickness is less than 4 milli and no other abnormalities, so the cause of bleeding will be atrophic change and the patient will be discharged. But if the patient come again with persistent symptom of postmenopausal bleeding, it's an indication for taking a biopsy. And if we did the transvaginal ultrasound and the endometrial thickness is proved to be more than 4 millimeters, at that time we will take fecal biopsy. Fecal biopsy has a false negative rate 10 to 15%. So if it is benign condition, I will treat her as atrophic. It changes as a cause of postmenopausal bleeding. Or it could reveal hyperplasia or malignancy, so I will follow the protocol. Or it may be inadequate or not possible to be done. At that time, we will offer the patient to do outpatient diagnostic hysteroscopy. And if failed, we will do the hysteroscopy under general anesthesia. So women with postmenopausal bleeding in UK do ultrasound first, depends on the thickness. You can take the biopsy if it is more than 4 milli. First, they do fecal biopsy. If fecal biopsy is not possible or inadequate, we will go to hysteroscopy outpatient. If failed, hysteroscopy under general anesthesia. Coming to the point of HRT. Use of HRT in endometrial cancer, there is theoretical risk of stimulating the tumor cells. However, the evidence is not clear about this risk. Therefore, women are treated on individualized basis, depend on the symptoms and prognostic risk factors. Because the risk of recurrence with hormone replacement therapy is unclear. So, if the woman is symptomatic for menopausal symptoms, she could be counseled on receiving low-dose combined HRT. After telling her about the risk is that there is a risk of recurrence, which is unclear, no available data about this area. So, depends on the symptoms. But if we can treat the symptoms without using hormonal HRT, we can offer that. Like if the patient has flushing, we can offer non-hormonal treatment of clonidine. If she has dyspareunia, we can offer vaginal lubricants. If we wanted to protect the bone, we can offer calcitonin. But it is expensive and given by injection. Also, the woman could receive progesterone alone because it can give some protective action to the cone, but on the other hand, it increases the risk of breast cancer. So while I'm counseling a woman on HRT, I need to emphasize, if she asked, because it is also not the station to discuss about HRT, but if she asked, I will tell her that because we are going to remove your ovary, you will start to reach the age of menopause. And if you suffer symptoms of menopause, we will do referral to a specialized menopausal clinic. In this clinic, they will discuss with you that because you have an endometrial cancer, there is a theoretical risk that the HRT will stimulate your tumor cell. So they will either give you minimum dose of combined HRT if you have symptoms of menopause, or they can give you alternative treatment. Hopefully it is clear now. If anyone have any question, let me know, please. Is there any question?
Hello, Dr. Rasha. It's Sumaira.
Yes, hello. Hi,
Ma'am, one question. Sometime in cancer station, patients are asking how much time I have to live now. So any idea to tackle that question?
Yes, you can tell here no one can answer this question, but depends on the stage and depends on the further workup. We can determine what stage you have and we can give you the surveillance rate. If it is clear here in this task that the surveillance rate is the stage is early, so your disease is discovered in the early stage, and if it is further confirmed, so the 5-year survival rate is more than 90. But you will not tell her how much time I will have. So you cannot answer, and even in real life, you cannot answer this question.
Yes, and if like in report, in confirmation of identification in report, is it okay to say just to save time during station that I confirmed your name, age, and NHS number, or
Yes.
it is must to that we have to ask again name and ask
No,
some number?
just to confirm, just to take the mark that you check the patient name and the identity.
Okay, and if that patient, if we ask about open question, can you tell me more about your menstrual history? And patient said that everything is fine, everything is fine. So still we have to ask about particular questions like intermenstrual bleeding or age of menarche or anything, or if it's
In this station, yeah, you need to mention. In this station, because you need to ask about symptoms of endometrial cancer. Just to confirm. She tells you, yeah, my cycle is regular and fine. You will confirm. So you don't have any bleeding in between your period. You don't have any bleeding after having sex. Just confirm. Let the examiner hear that you know and you are aware of the symptoms of endometrial cancer.
very good idea. Yes. Okay. Thank you.
You're welcome. Any more questions?
Dr. Rasha, Dr. Rasha, I missed history point because I thought it is targeted history. That is why I did not take a detailed history. From next time, I'll take care of it. Thank you.
I'm sorry, Dr. Sharda?
I'm saying that I thought I have to take a targeted history. That is why I did not take the detailed history.
Oh, yeah, it's okay. It's okay. No problem.
Thank you.
Doctor, I actually missed the session, but I have one doubt, doctor. You said when endometrial thickness by ultrasound is more than 4 mm, we do a endometrial sampling, isn't it? So it should, in case of postmenopausal women, is it always better to go ahead with hysteroscopic sampling, or we should say pipal biopsy first?
No, they start with pipal biopsy first. Then, if it is inadequate, they go for outpatient hysteroscopy. If failed, for inpatient hysteroscopy. And when you counsel the woman, you will tell her that the false negative rate is about 10 to 15%.
But in the NICE guideline, I'm not sure, but it was given that blind biopsy is no longer recommended. When people biopsy,
yeah, I agree with you. I agree with you that it is written in NICE guideline about that. But this is the current practice. Here, the current practice is starting by pupil biopsy, then outpatient hysteroscopy, then inpatient hysteroscopy.
Okay, doctor. Thank you. Thank you.
Welcome. Any more questions? So, Dr.
Rasha, I have a doubt. In this, starting the question, actually, you are an ST file, you are asked by the consultant to see that patient. Do we need to take an excuse that consultant is away or something like that in this, or
no,
because
no, just tell her I'd like to take the consultation on behalf of my consultant. That's it.
Okay, that is needed actually.
Yeah. That's all needed. If she asks you, no, I expect the consultant, you can say, I'm sorry because he's busy, and if you want, I can arrange another meeting, but this will not occur in the exam. Just make sure, I'd like you to tell the examiner that you are aware that the consultant is absent and I'm taking his role in counseling the woman. Just
Consult is
tell
not
her, I would
like he just asked you to take this, just discuss the results.
Yeah, take permission for that, and she will agree for that. But in real life, yeah, the woman may disagree and will say that I'd like to be seen by the consultant. If it is the case, you will postpone her appointment until the consultant will be available. But in the exam, she will agree.
Okay. Thank
you. You're welcome. I think other doctors were asking for participation. Who would like to share the next one?
Yes, Dr. Rasha.
Yes.
Yes. So we have Dr. Salma and Dr. Ibtihal. Dr. Salma for the next case and Dr. Ibtihal for the other case. Okay?
Okay, thank you. Okay.
Thank you.
Dr. Salma?
Yes.
Here is your case. You would like to see the questions?
Sorry. The first one, doctor. Can I see the? Yeah, next.
The other slide?
Yes, next. Next, please. Question. Question, please.
Can you start, please?
Hello, I'm Dr. Sharma, one of the candidates today, and I'm ready to answer your questions.
Okay. Did you read the scenario? Did you read your questions?
Yeah, this is a case of borderline ovarian tumor. So
why it's
I'm ready
important to
to
follow a
answer.
patient who had unilateral salpingoparectomy for mucinous borderline ovarian tumor after surgery, and what is the follow-up arrangement you will arrange?
Yeah, so it is important that for follow-up, if patient is unilateral salpingoparectomy for mucinous borderline ovarian tumor after surgery, because there is a chance that 10 to 20% the patient will have the contralateral, the ovary that recurrence. So that's why she needs follow-up appointment. So this follow-up will give, because in early few years, she has more chance for recurrence. So we'll give 3 monthly for 2 years that follow-up, and then yearly we'll give for 5 years total.
Okay.
And also what we'll follow up this case, that means CA 9 to 19. This is for mucinous borderline ovarian tumor, that blood test will follow up, and also ultrasonography and clinical examination also. Thank you. Next.
So, if while explaining the results of histology to patients, you are required to explain the diagnosis of borderline ovarian tumors with invasive and non-invasive implant, how would you do it?
Yeah, so if there is a diagnosis of borderline ovarian tumor, so invasive and non-invasive, so this is first we'll see that it is early stage or that or advanced stage. So
can you start how you are going to discuss with her the diagnosis of borderline ovarian tumor? How to explain that to the patient?
Yeah, so I'll explain to the patient that actually that with her, first of all, with her name and NHS number, I'll confirm that to the patient, and then I'll explain to her that this is, first of all, we'll ask her she has any idea about that. Anybody explain to her this about the tumor? So if she doesn't know anything, so then I'll explain to her with empathetic and sympathetic way, and then I'll tell her that yes, Mrs. Say, for example, any patient that, yes, this is a slow-growing tumor, and it is arising from the surface of the ovarian ovary surface layer, and it is not invading the supportive tissue, and also it is not the cancer. So that's why we'll give you follow-up, and we'll give you the treatment to make you that not to get cancer, but it is not cancer.
And how to discuss about invasive or non-invasive deposits.
Sorry, I cannot hear you properly.
So how to discuss about invasive or non-invasive deposits?
Yeah. So invasive and non-invasive. So this will be, there is an early stage and later stage. So it is invasive. That one is which is advanced stage. Okay, advanced stage. So this advanced stage, it will invasive. So that means it is will teach her the treatment. There will be different because it is already impaired the more impaired the tissue. So it will be that that management of treatment, it will be different. That will do the staging like a total hysterectomy, bilateral surgical operation. But in case of the non-invasive implant, so that means it is not invade more. It is non-invasive, so it is early stage. So it depends on the that she wants the fertility or not. So if she wants fertility, then we'll give her conservative management. That will not go for the that total hysterectomy and bilateral surgery. That means we'll remove only the affected the ovary, and then when she's complete,
I'm not asking you about the management plan, how to explain in lay language to the woman that she has invasive or non-invasive implants. How can you explain this term in lay language?
Yeah, I'll explain her that it is early stage. The non-invasive implant, it is early stage. So that means it is not invading your tissue more depth. Okay, so that's why it is, yeah.
And how would you explain about histological grading?
Invasive, that means it is involve the tissue more depth. Okay, so that's why the tumor is more deeply embedded in the tissue.
How can you explain about histological grading?
So histological grading, that means that the cancer cell we'll see under microscope. That means to see the cell how it is going. So with the grading, we'll see that it is slow growing or rapidly growing. So then, according to this and how it is embed the tissue, how much depth, so we can see the in the microscope. Then we can grade it properly. Whether it is low grade or high grade.
So it will depends on invasion.
It depends on the yeah, it depends on the how it is going, the how rapidly the cell is going, and also the depth also we can see.
So you mean that it depends on the depth of invasion? Is that what you mean?
Yes, depth, and also that depth, that how much it is depth.
Okay. So what steps you will take to know the histological diagnosis of borderline ovarian tumor after ovarian cystectomy?
Yeah. So after cystectomy, then we'll explain to the patient that we'll ask her about the fertility option first, and if it is early stage, okay, so that means we can tell her about the conservative management. That means we'll remove only the affected ovary, and then we can explain to her that there is a risk that contralateral ovary could be, there is a recurrence. So we'll remove the other ovary also, but it depends on her fertility issue. So after completing her family, then we can do that total hysterectomy and bilateral self-hysterectomy.
So it means that after doing ovarian cystectomy, you will counsel her to do, if she's fertility wishing, to do ovarectomy for this ovary, or you will leave this ovary which you did for her cystectomy?
No, if it is, that means after cystectomy, if she has, that means if she is early stage or she wants fertility, so then we'll remove only the affected that ovarectomy.
Okay.
On that ovarectomy, but I explained to her that we'll give her follow-up appointment, that because there is a recurrence rate that other ovary could be recurrence. So that's why we'll give her follow-up appointment, and then later on we'll remove her that the other ovary also after completing her family. Yeah, and then it is early stage. But if it is advanced stage, then we'll explain to her that I will ask her about the fertility issue. So if she wants to get pregnant, so after completing her family, then we can do her total hysterectomy with bilateral self-hysterectomy. And we'll give her follow-up appointment also with clinical ultrasonography and also the CA1, CA9-19.
Okay, Dr. Salma, thank you for sharing. Who signs up?
Okay.
You managed to answer most of the question, right? But I'd like to, I will explain the answer of this question first, and you will recognize what you did in your answer, okay?
Okay, thanks.
So let's go through one question by one. The first question is, why it's important to follow a patient who has had unilateral salpingo-ovarectomy for mucinous borderline ovarian tumor after surgery? So as Dr. Salma said, because there is a risk of recurrence in the contralateral ovary after unilateral salpingo-ovarectomy, so we need to have strict follow-up for those patients. The risk of recurrence is 10 to 20%. You did it well until that about the risk of recurrence on the contralateral ovary. Then how we will do this follow-up? She also said rightly that we need to do the follow-up until completing the surgery. And this will be every 3 months in the first 2 years, then every 6 months for the next 2 years, then annually. Actually, the manner of follow-up differ from one unit to another, from trust to trust. It is not clear. But the standard in most articles that I review is like that, to be followed every 3 months in the first 2 years, then every 3 months, 6 months in the next 2 years, then to be done annually. And what you will do during the follow-up in each appointment, you will do transvaginal. In the start, you will ask about symptoms. Make sure that you don't have any change in her appetite or new onset of abdominal pain or change in the pattern of period. And you will perform a transvaginal ultrasound. And if on the initial diagnosis, the tumor marker CA125 and CA19-9 were elevated, you can use it during the follow-up. So, Dr. Salma, you answer this question correctly about why we need the follow-up and how we can do this follow-up. The next question is, while explaining the result of histology to patient, you are required to explain borderline ovarian tumor with invasive and non-invasive implant. So, how can I explain to a role player in a lay language the diagnosis of borderline ovarian tumor? I will do this through. First, I will draw for her. This is the ovary, and we have the outer layer, which is called the cortex. This is the supportive layer of the ovary. Now you have a condition which is a tumor, which is totally different from ovarian cancer. because the growth is limited to the ovary and it never invades the supportive tissue of the ovary, which we named cortex. This type of tumor is low malignant, differ from original cancer or conventional cancer because it grows slowly and in more controlled manner. So when I explain to the role player, I will first draw, here is the ovary and here is the outer layer from named the cortex. Then tell her this type of tumor arises from the ovary, but the good news that it doesn't invade through the supportive layer and it grows slowly in a more controlled way than conventional cancer cells. Going to non-invasive and invasive implants, simply non-invasive implant meaning is that deposits which don't invade the underlying tissue, because in borderline ovarian tumor metastasis could be non-invasive or invasive. Non-invasive meaning is that it doesn't invade the underlying tissue, while invasive invading the underlying tissue. But still, the behavior, the outlook generally will be better than conventional ovarian cancer, meaning is that if a patient with borderline ovarian tumor and has even invasive implant, if it is confirmed, for example, to be stage 3 borderline ovarian tumor, her outlook is much better than stage 3 conventional ovarian cancer, even if the implants are invasive. So that's how I will explain this to the patient. We can explain histological graining. The other question, how, be careful Dr. Salma, because histological graining, it doesn't depend on the degree of invasion. It depends on how the cells look under the microscope. So we have grade 1, 2, 3, or low grade, moderate grade, high grade, or well differentiated, intermediate differentiated, and poorly differentiated. All are the same names. For grade 1, the cancer cells look similar to the normal cell and usually grow slowly and less likely to split. In grade 2, the cancer cells look more abnormal and are slightly faster growing. In grade 3, the cancer cells look very different from normal cells and grow more quickly. This is the correct answer. Grade 1 and 2 and 3 depends on how the cells look under the microscope, how far it is from normal cell, and the way it is spread, if it grows slowly or more faster or more quickly. Is it clear? And the last question is, what steps you will take if you note the histological diagnosis of borderline ovarian tumor after ovarian cystectomy? And you mentioned most of the management plan, Dr. Sanna, but don't forget that you are not the one who is caring for this woman. Don't forget MDT, and don't forget that this patient needs to be referred for specialized cancer center. Okay? It's really important. Don't forget MDT. So what I will do if I discover the histological diagnosis of borderline ovarian tumor following ovarian cystectomy? So we will arrange an urgent appointment for this patient to discuss about the diagnosis, better in presence of specialized cancer nurse. I will discuss that the risk of recurrence of borderline ovarian tumor following cystectomy is high, up to 58%. That's why another surgery will be required. But her care follow now will be under MDT in a specialized cancer center, and they will encourage her to perform further imaging, which is MRI. Be careful, in borderline ovarian tumor, the imaging modality is MRI, like endometrial cancer. But ovarian cancer, conventional ovarian cancer, the standard imaging modality is CT. So here the imaging will be by MRI. Then I will discuss with her about the possible treatment option, which if she is seeking fertility and she is still in early stage, usually you will recommend unilateral salpingo-ovarectomy on the affected side with omental biopsy, peritoneal biopsy, and in mucinous type, they will also perform appendectomy plus follow-up. But if she doesn't require fertility, and if it is in late stage, so the standard treatment will be bilateral salpingo-ovarectomy with total abdominal hysterectomy, omental and peritoneal biopsy, and appendectomy if mucinous type. Hopefully it is clear now. You covered most of the point, Dr. Sanna, and you did very well, but remember about the point of histological grading. And don't forget about MDT and cancer cells.
Yes, I actually know that low grade. When you ask me repeatedly, then I changed my mind and I told that.
No problem. I know it's
sorry.
Yeah. Okay.
Thank you very much. Thank you.
You're welcome. Dr. Razia, I'm really sorry because I promised Dr. to do the next session, but hopefully on the next session you will do, inshallah.
Dr. Rasha, can you show first slide?
The last slide?
First, question one.
Question, okay. Anyone have any question related to borderline ovarian tumors?
Oh, first answer
Any
one.
question?
After that, second slide.
Oh, okay. Okay, Dr. Ittihad.
Hello.
Hello, Dr. Ittihad.
Yes, welcome, Doctor.
Please all mute yourself. Or is Dr. Ittihad being unmuted?
Dr. Rasha, you said MRI is a imaging modality if it is a borderline ovarian tumor, but whereas CT we have to go ahead if it is for cancer. Am I right, or I heard it in a wrong way?
I'm sorry, can you repeat your question?
When you were telling about investigations, MRI you told for borderline ovarian tumor,
Yes,
and you
yes.
told something CT scan will be better if it's a cancer or something.
Yeah. The imaging modality in endometrial cancer, MRI. Borderline ovarian tumor, MRI. But conventional ovarian cancer, CT scan.
Okay, conventional ovarian cancer, it is CT scan.
CT scan, yeah. For staging for ovarian cancer, order CT scan. But borderline, MRI. This is the recommended imaging modality, okay?
Okay.
Shall we do the last station or any questions? Okay, Dr. Ken.
Yes.
You have now 2 minutes.
Okay.
Can you see your case? Can you see it?
Yes. I don't know yet. This is the previous. Yes, now it's okay, clear.
So your 2 minutes starts from now.
The simulated patient role player. Okay, just 2 minutes.
Okay. Can you start, please?
Yes. Hello.
Hello.
I'm Dr. Abtihal, one of the doctor in Gyne clinic today. May I confirm your full name and age, please?
Yeah, I'm Mrs. Mary Davis. I'm 62.
How are you doing, Mary? It's
Yeah,
okay
I'm
to call
fine.
you Mary?
Yeah, that's fine.
Okay, you can call me Ibtihal then. Um, Mary, what I understand from your referral letter, you are here today because you have some like abdominal bloating and some complaints. So your GP referred you after he did some test and some scan. So he referred to discuss the management plan. Am I correct?
Yeah.
Okay. Mary, if you don't mind, just I need to share with you some important information. It will help us to know more about you. Then we will put the plan of your care. And after our discussions, I will give you some useful leaflet to detail what we said. And I will write back to your GB and
What leaflet you
fix
will
for
give
you
me, doctor?
appointment.
What I have?
How is that is okay? Sorry?
What leaflet you are going to give me? What I have?
Okay, no problems. You want to know the result first?
Yeah, as you
May I
want.
ask you a
Okay.
few questions? Okay, I want
Okay.
just to ask you a few questions. Can you tell me more about what complaint for which you went to your GP?
Yes, well, I've been suffering from abdominal bloating for the last 3 months. So I went to my GP and he arranged a blood test and a scan for me after failure of the treatment I have received. And I'm here to discuss about the result of this scan.
Oh, okay. Other than this abdominal bloating, anything else?
Like what?
Like, yeah, like if you feel like your tummy increase in size, you feel your weight is decreased, become less, nothing.
No.
Okay. What about your smear, Mr. Mary?
Yeah, all are normal.
It's normal. Okay. Are you using any treatment like hormone replacement therapy or anything for something chronic?
No. No.
Nothing. Any other health issue?
For me, no.
Okay. For your family, any history of chronic disease, any history of cancer, anything significant?
Yes, actually, my mom died at the age of 40 because of breast cancer, and I'm really worried because I know that breast and ovarian cancer run in family, and I'm really worried about the risk for my daughter.
Oh, I'm so sorry. I'm so sorry, dear. Yes, please accept my condolence. What about the things at home? With whom are you living right now?
Yes, I live with my husband and my daughter.
Okay. Are you supported well at home?
Yeah, I have a fine support, thank you.
Okay, dear. You have one daughter. Any else children you have? Only one
No,
daughter?
actually, I have only one daughter which was conceived via IVF and ended by vaginal delivery at home.
Okay. What is her age right now?
She's 23.
Okay. Miss Jane, just let us come to talk about the report now you have. I saw you came alone now. Just if you don't mind, because a lot of information I may need to give you, so I can call one of our staff to support you. That's okay.
Why?
Just a lot of information. It may be difficult to
No,
bear
it's
alone.
okay, doctor. Carry on.
Oh, okay. Mr. John, actually, the test done for you in
Doctor, my name is not Mr. John. My name is Mary. I'm not Mr. John.
not Miss
Guess
John.
what?
Okay.
Don't do
Okay.
this.
Yeah.
Okay,
Okay,
let's go.
Miss John. Okay, Mr. Mary. Actually, the scan done for you and blood.
Doctor, not Mr. She's Mrs. Mr.
Mrs.
is
John.
for men. She's Mrs.
Yeah, Mrs. John.
Let's complete. Okay.
Yeah,
And
Miss John. Actually,
okay, carry on.
Okay. The report done for you, the blood test and scan, it gives a high suspicion that you may have a sinister in the ovaries. It is not confirmed. We cannot confirm by the test alone, But from the test, we need to
What do you
take
mean,
further
doctor?
action.
What do you mean? You mean that I have cancer?
No, we cannot say right now. But from the finding of the test and the blood and the scan, there is a high suspicion. For the women like your situations, the chance will be higher. So we need to take a further step. First, yeah, group of our colleagues, they are the one will take care of you. So I will arrange for you a further imaging.
Doctor,
And
I can't understand all of this information. You told me that I have cancer. I have high risk to have cancer. I'm really worried about my daughter. This is my worry. I want that cancer run in my family.
I'm talking with you, Miss Mary, about what step we are going to do right now, because we cannot confirm a cancer unless we take a sample and send to the lab. But for your situations, from information I get from you, your mom died because of cancer. The test done for you now also, it is not reassuring, Mary. So we need to send you for surgery. It is the one will give us the final diagnosis. But before that, as I told you, the management will be a group of a colleague. They are the one come with it with you after further tests will be done, further imaging I mean, and then they will discuss with you the option of care. Am I clear so far?
What are the options that I have?
The option, the preferred option, they will do for you a surgery, what we call a full staging surgery. That means they will open your tummy and they will remove the womb and the ovaries and some tissue, and they will take also if there is any fluid and send to the lab. After the result came, again they will be a meeting with you. They will tell you about the final result. Hope everything will be okay, but in case there is any sinister cell or it is cancer, then they will tell you the next step if they need to give further medicine like drug killing agent or not. Regarding your daughter, Mary, because there is a family from your mom and from your finding, we will send you also to one of our colleagues, what we call genetist. They will take test for you, and if you are carrying, because this sometime it is running in the family, there is one gene, it may run in the family. If you are positive for that one, they may need to check for your daughter as well. Am I clear so far?
Okay. So I just inquiry. You told me it's a high risk. So I'm going to have this major surgery. Depends on this risk. Told me that they are about to remove my womb, my ovaries. It's a big operation.
Yeah, because what we did now, right now, we will calculate your risk according to your age, according to the blood test done for you, and according to the scan. For the women like your situation, the risk will be about 7 out of 10 ladies. It may be a cancer. So it is not, and it is considerable risk. We cannot ignore. Am I clear, Mary?
Okay.
I'm so sorry, I'm the one bearer for this information. But as I told you, I will fix for you appointment with my consultant and with our team. Then you can come with your husband, and I will write back to your GB about what our plan. Till that time, I will give you my contact number and some support group for people same problem like you. You can collect your information till you will come, and we will see what is the next step after this imaging we will do, because we will request for you a further imaging like a CT scan.
You are really, I can't understand you. You mean that I'm going to have a surgery or I'm going to have a CT?
No, this surgery, I told you about the plan, what we will do by the team, what they will do, their plan. But to prepare for that one, we will do a more test, so everything will be clear.
Okay, clear now. Thank you, Dr. Ftihar.
أنا مستر دي أصلا طبعا ما بقدر أخليها. Sorry.
Be careful because it will be a great mistake if you did it.
Yeah.
Practice more, and be careful when you pronounce the name of the patient.
Yeah,
Thank you
okay.
for your participation, Dr. Ftihar.
Thank you.
So you did it well, and you confirmed the aim of the consultation, and you put your agenda, and you ask about the family history, which is relevant here, and you ask about the social support, and you ask about obstetric history because NADIPAR is a risk factor, and you emphasize the importance of MDT, and later you discuss about the importance of CT scan. But I have some consideration in your performance. From the start, when you put your agenda, don't tell the patient that I will give you leaflet as long as you not yet tell her what diagnosis she has. When you told her that there is a possibility that you have cancer ovary, at that time, tell her that I'm going to give you patient information leaflet about ovarian cancer and put you with support with the Macmillan support group. So don't tell leaflet or support group as long as you don't tell her about the diagnosis, okay? The other issue, as you realize, be careful when talking about the name of the patient. It is not only that you said Mr. You also tell a wrong names. Sometimes you tell Mary, somebody John, somebody Davis. Okay. If you will not be able to tell the patient name correctly, don't mention them. At least you will not be penalized for telling the name in a wrong way. But try to participate doing the name, and even when you practice with your study partner, try to change the names. Don't be restricted with one name. Try to use many names so you will be familiar with different names in the exam. The other issue that you missed to talk about allergy, and you missed to ask about smoking and special habit in general. And also, when you break the bad news, I cannot feel that the tone of voice or your communication with me that you are going to tell me bad news. It is the same tone of voice. I can feel that there's something wrong. And even when you told me about the diagnosis, when you told the role player about the diagnosis, especially if it's cancer, wait, don't tell her a lot of information. Just tell her you have cancer of the ovary or you have high risk that you have cancer of ovary. Then wait until she can respond to this information. Don't overload her with many information about her management plan or any further modalities. Tell her the diagnosis, then wait until you can see her response. And please check
sorry, Dr. Rasha.
Yes.
Yeah, we will consider here like ideal breaking bad news because still no histological report.
Yes, still, but there is high risk. It is 3 and 4. 3 and 4 that she has a family ovarian cancer. It is not yet confirmed. I agree with you, but it's high risk 3 and 4. So yeah, it's breaking bad news. Okay, and also before telling her about the result, to confirm the patient name and the NHS number, and checking understanding of the role player. Be careful with that. You give me a lot of information in one paragraph. You don't wait. You don't ask me about if you are clear, if I understand you. So junk your information and check understanding and draw for her about the results. Okay, and also CT scan is the first thing you will do before referring her even. So emphasize this point from the start. Time can run out and still you didn't mention about CT, which is an important point of safety and applied knowledge. Okay, Dr. Tina?
Okay.
Thank you for your sharing. Thank you.
Okay, thank you so much, Dr. Rasha.
So now going to this task, in the 2 minutes, what we are going to emphasize that it's a role player task. I will check the domains. Yes, there is information gathering, so I'm going to take a detailed history. There is communication with colleagues, so I will write down MDT. The patient name is important. The patient age is important. She's 62, and also the main complaint, which is abdominal bloating. I will write down that she has elevated CA 125 and the finding of the ovarian cysts, and I will draw this during explaining to her the result, and I will be reading what is needed from me carefully to take a relevant history, explain the investigation, formulate a management plan, and answer her concerns. So, what are the important points in this First of all, still, as you can see here, it's written in the station, you have been asked to see Judith Davis. Although it is not written that the consultant is away, but what you understand from this sentence, you have been asked. So the woman is not suspecting the registrar to counsel her. So still, you need to take permission to start the consultation on behalf of the consultant because you have been asked. So I will start the consultation that I'd like to start the consultation on behalf of my consultant. You need to assess the patient's main concern. The main concern here is that she is keen that the cancer run in family and she's keen about the risk to her daughter. Don't neglect her concern. You can postpone it until the end of the consultation, but tell her, yeah, I appreciate your concern, and after telling you about the result, I will answer your concern. The other issue that establish what she already knows, if anyone told her about the result or not. Then take a target history. Ask about the symptoms of ovarian cancer, any change in weight or appetite, bowel or bladder symptom. All of you forget today to ask about bowel and bladder symptom. It is relevant in any cancer patient to see if there is bowel invasion or bladder invasion or not. So ask, do you experience any change in your water work or in your bowel? Any bleeding attack, any lower abdominal pain, any painful sex, any medical or surgical history, smoking, because all of this will increase the risk for her further surgery. Ask about her BMI, the risk factor. Ask about obstetric history, which is also a risk factor. Ask about contraception, because COCB decreases the risk. So you need to ask what type of contraception she used to use. And also social support is very important in any woman with cancer. Since when she started the age of menopause, any HRT has been received, any family history of cancer, breast, ovary, bowel, and when I'm going to discuss the result, confirm the name, the NHS number, and breaking bad news approach warning shots. Can you see in the image in this slide? During this consultation, this doctor make a mistake. Can you see what is the mistake? Can anyone recognize the mistake she did, which we all did in the exam, most of us, not all? What is the mistake here in communication? Can you realize?
She's not looking to the patient.
Yes.
No eye-to-eye
Great.
contact.
Yes, yes. Don't do this in the exam. And even if you want to go through the notes again, take permission of the patient. I'd like to have a look on your report, then I will discuss with you. And as you can see, the role player here is who concerned, try to make a good communication with her through your body language and through eye-to-eye contact. Then we are going to interpret the result. I will draw for her. Here's your ovary, and we have here a cyst, which is having solid area within it. And your GB has ordered the protein named CA125. Depends on the finding of the ultrasound and the finding of that protein, we are highly suspecting that you have cancer of the ovary. So wait, because it's breaking bad news until she can react. Then when she is fine and after breaking this bad news, when the patient are able to discuss about the management plan, discuss about it now. We need to do a further imaging like CT scan of abdomen and pelvis to give us idea about the stage. And from now, your care will be under a group of health team, health professional named MDT. Your care will be in a specialized cancer center. And the MDT oncology team will recommend full staging laparotomy. Let me draw it for you. Then draw for her. In this operation, they will remove both ovaries and tubes. This is named bilateral salpingo ovarectomy. They will remove the womb and the cervix, and this is named the total abdominal hysterectomy. And they are about to remove the fatty layer of the tummy. We name it omentectomy. Am I make sense? Check understanding. Then, depends on the stage and the grade of cancer, the surgery could be followed by chemotherapy. So discuss all the options. You forgot to mention that there is a risk that, or there is an incident that she may require chemotherapy. Coming to the patient concern, she's concerned that her daughter will have cancer. So tell her that, yes, hereditary ovarian cancer is found in 1 in 10 of ovarian cancer. And this is caused by a faulty gene, which we name it BRCA1 and BRCA2. But at this point, it is not certain that there is a cancer, or if it contains BRCA gene mutation. So a lot of information will be gathered when the cyst is removed, when the operation will be done. And if needed at the time, we will make a referral for a genetic center for proper counseling. Then give her patient information leaflet, support group, and offer meeting with counselor. In this diagram, in any woman who presenting with suspected ovarian cancer, what we do? We will do CA 125, this is in the primary care, the GB will perform for her CA 125, an ultrasound of abdomen and pelvis. And still, if the woman under 40, be careful from the age of the patient. In the exam, if you have the role player under 40, you need to request further markers. You will tell her we are going to order other blood proteins. We name it alpha fetoprotein, beta HCG, to rule out any other diagnosis. Then calculate the risk of malignancy index. If it's more than 250, and in some sources more than 200, we will do a referral for MDT. And in the ultrasound, the A125 and the clinical status would suggest ovarian cancer. So we order CT scan in abdomen and pelvis. And if from the history you suspecting this woman have symptom of chest metastasis, we can order also CT scan of the thorax. Then we don't use MRI routinely. Be careful. In ovarian cancer, we order CT scan. Ovarian endometrial cancer, MRI. Then offer information on ovarian cancer and meeting with a counselor as well. In terms of BRCA1 and 2, how to explain this to the role player, I will tell her that these are BRCA1 and BRCA2 are human genes that produce tumor suppressor protein. These proteins help to repair damaged DNA, so play a role in stability of cells' genetic materials. If we have mutations of this gene, this could increase the risk to ovarian and breast cancer. If she would like to know more about the BRCA genes. Okay? And I'd like to emphasize that in the exam or even in another station, be careful when you read the scenario, because sometimes in this station, it is not sure that she has ovarian cancer. So you are talking about high risk, which is 3 and 4. So you will not tell her that you have ovarian cancer, because there is still other possibilities. But another scenario could come and you have the result of the CT scan and will be written clearly that the patient has ovarian cancer. So here the way of counseling will be different. You will confirm it that she has ovarian cancer. So be careful when you read the station, whatever it is written clearly, she has ovarian cancer, or it is not written, so you are talking about high risk. Hopefully it is clear now, and if anyone have any question, let me know.
Dr. Rasha, can we see that previous slide, please? Not that one.
The previous slide. Okay.
That is from last. From last, if you start that third one. Not this one. The other one. This one.
Any more questions? Thank you all.
Thank you. This one.
Yeah.
This is the one. Thank you.